My name is Peter Gotzsche. I'm a director of the Nordic Cochrane Center in Copenhagen and professor of research design and analysis at the University of Copenhagen. 2 years ago, I found out that our prescription drugs are the third leading cause of death after heart disease and cancer. Our drugs kill around 200,000 people in America every year, and half of these people die while they do what their doctors told them. So they die because of the side effects. The other half die because of errors. And it's often the doctors that make the errors, because any drug may come with 20, 30 or 40 warnings, contraindications, precautions and so on. So they give patients drugs that they should not have given them, that interact dangerously with other drugs or food items or so on. And then the patients die. That's the other half. The other thing I found out 2 years ago was that much of what the drug industry does fulfills the criteria for organized crime in US law. And they behave in many ways like the mafia does. They corrupt everyone they can corrupt. They have bought every type of person, even including ministers of health in some countries. So there is a huge amount of corruption. In my country, for example, Denmark, we are regarded as having very little corruption, but yet we have thousands of doctors on industry payroll, although we are just 20,000 doctors. So this is an effective kind of corruption. The drug industry buys the professors first, then chiefs of department, then other chief physicians and so on. They don't buy junior doctors. So when several thousands are on industry payroll, it's really, really bad. And that's why I wrote my book, Deadly Medicines and Organized Crime, How Big Pharma Has Corrupted Healthcare. I hope to convince patients not to take so many drugs, because so many die from the drugs they take. In my country, people take so many drugs that every single citizen can be in treatment with 1.5 drugs from they are born till they die. This is incredible, and drugs are not that helpful. They kill very many of us. We know that. That's why drugs are the third major killer after heart disease and cancer. So what we need in the coming years is to take far fewer drugs than what we do currently. If we did that and we were careful, then we could live longer and live better lives. Because drugs have many side effects, and patients often don't realize that when they become worse, that it could be a side effect of the drug, which they continue taking because that's what their doctors tell them. So when I was a specialist in internal medicine, what I very often did was that I stopped a lot of drugs, particularly in elderly people. And it's quite revealing to see a bedridden elderly person come into your ward, and when you stop the drugs, I mean, that person becomes many years younger. Many of these drugs affect the brain, and old people tolerate that very, very badly. They fall, and when they break a hip, 1/4 of them die. And for example, antidepressant drugs are used in more than 10% of our elderly. They seem to kill 3% of them every year. I mean, if 100 old people take an antidepressant for 1 year, 3% of them will die because they fall and break their hip. This is a huge death rate. So a lot of other drugs than antidepressants also make people fall and kill them. And they may affect your cognition, your memory, and all these things. And then they interact in ways that we know almost nothing about. Very many elderly, they take more than 5 drugs a day. And we actually don't know how these drugs interact with each other. What we do know is that all drugs have many effects in the body, and some of them interact also in their metabolism, so that you can get a too high concentration of a drug if you take other drugs simultaneously. So we make a lot of harms that we don't even recognize. I have a pretty colorful collection of things people have called me during all these years. And sometimes journalists have asked me, why do you always look up controversy? And my reply is, I don't. Controversy looks me up. Because it's not popular to tell the truth in healthcare. You will get a lot of enemies, because a lot of people make money on false premises, doctors and industry alike. And our drug regulators and our politicians, they are on board on this wagon. Very few people are independent of money in healthcare. And of course, I have attacked a lot of holy cows during my career, and people have screamed loudly. In a French journal, I was called a statistical masturbist because I showed with statistics that mammography screening didn't work and things like that. And I was even accused of scientific misconduct by the Association of the Danish Pharmaceutical Industry, which was completely ludicrous. It was harassment from beginning to end. They came with vague arguments that we cannot recognize the conclusions in your study, and they could have come up with numbers and said, these numbers are wrong. They didn't do anything. It was only harassment. It lasted 18 months, I think, the whole thing. And then when we were acquitted, I made sure that this nasty behavior was described in the British Medical Journal. So after that, they haven't come so much after me, the Danish drug industry. And when my book about organized crime came out, they just lied about it, as they always do, that my examples were old, they went back 90 years and so on. But, you know, where I demonstrate that what the 10 biggest companies do is organized crime, these examples, they were from within the last 10 to 15 years. That's not old examples, and the crimes have increased because when crime pays, you will have more crime. That's how capitalism works.
I'm Jim Gotzsche with the Law Project for Psychiatric Rights.
And I'm extremely pleased to introduce our speaker tonight, Dr. Peter Gotzsche from Copenhagen. He's with the Cochrane Collaboration. Cochrane, an independent research group that they don't have any conflicts of interest, and they're known around the world for their objective review of what the research really says. Dr. Gotzsche has published over 70 papers in the 5 most prestigious medical journals in the world, and they've been cited over 15,000 times. He's published 4 books: Rational Diagnosis and Treatment, Evidence-Based Clinical Decision-Making, Mammography Screening, Truth, Lies, and Controversies. Those are his first 2 books. And then in 2013, he wrote Deadly Medicines and Organized Crime, How Big Pharma Has Corrupted Healthcare. And then last year, he wrote, well, in Deadly Medicines, he had 2 chapters on psychiatric drugs. And he decided to write a whole book about that. And last year, he published Deadly Psychiatry and Organized Denial. I've got a few copies here if someone wants to buy them. It's just really excellent. Please welcome Dr. Peter Gotzsche.
Thank you so much, Jim. I really admire Jim's work, and I also cite it in my psychiatry book. I should say the crime book, the 2 chapters on psychiatry. The first one is called Psychiatry, the Drug Industry's Paradise. And the next one is called Pushing Children into Suicide with Happy Pills. It's a very dark chapter. A psychiatry without forced admission and treatment is a must. And I have no conflicts of interest, and of course the views presented are mine. What else could they be? There are 3 perspectives you can apply on the use of force in psychiatry, and I will discuss mainly antipsychotics. The scientific one is, does force do more good than harm? I believe clearly no. And antipsychotics cause vastly more harm than good. Ethics, is force ethically acceptable? No. Antipsychotics kill a lot of people and cripple many more. legal issues. International declarations are being ignored. I'll come back to that. So we must change our laws because they are unjust. Now, first of all, do these drugs work? They are not specific as the name implies. Anti is a misnomer. Antimicrobial agents can cure us from infections. Antipsychotics don't cure anybody. It's a misnomer. And the placebo-controlled trials are highly flawed because they are not adequately blinded. These drugs have many side effects, so most doctors and patients will know whether they get active or placebo, and then the effects will be exaggerated. In virtually all trials, you take people who are already in treatment, and then you have a short washout period of typically up to a week, and then you randomize to placebo or another antipsychotic drug. That means that you create abstinence symptoms in the placebo group in quite some patients. So you introduce harm in the placebo group. And then you conclude that my new drug is better than if I harm the control group patients. That's not good science. It's appallingly poor science. But that's how virtually all psychiatric drug trials are being done. Despite these heavy flaws, the effect of antipsychotics in recent submissions to the FDA is actually so small that it's doubtful it's clinically relevant. So the Food and Drug Administration have approved olanzapine, risperidone, and drugs like that, despite the fact that the effect they have in deeply flawed trials, so this is exaggerated, is below what you can barely perceive as a change. So that tells a lot about these drugs. And then the schizophrenia diagnosis can be wrong in over 50% of the cases. So you subject people to forced treatment with very toxic drugs, and they don't even have an indication for treatment because it's wrong. That's another sign that we are not doing well here. The cold turkey design is clearly lethal. One in every 145 patients who entered the trials for risperidone, olanzapine, quetiapine, and sertindole, they died. And these deaths are unknown to the public. They don't appear in published trials reports, and the FDA didn't require them to be mentioned. That's pretty typical for the FDA. This is an agency that, by and large, protect the drug industry and not the patients. And we are not much better in Europe with our European Medicines Agency. Now let's look at the first of these drugs. Antipsychotics are really psychiatrists' poster child. And the first one was chlorpromazine that was launched in 1954. And in the beginning, the psychiatrists were sober because they called it a chemical lobotomy, because it worked like lobotomy. People became quiet, apathic, or a chemical straitjacket. These drugs have no specific antipsychotic properties, but they lessen all thoughts. So it's difficult to exist when you take antipsychotics. 1 year later already, the hype was extreme. It was forgotten that this is a chemical lobotomy, and Harold Himwich, the president of the US Society of Biological Psychiatry, came up with a totally absurd idea that antipsychotics work like insulin for diabetes. It was purely fantasy. People with psychosis don't need anything. They are not short of anything. And then psychiatrists like to say that these drugs emptied the asylums. Miraculous effects. That's certainly not true. The asylums were emptied for economic considerations, both in the United States, in the United Kingdom, everywhere where it has been studied. It had nothing to do with the effect of antipsychotics. So this is part of the folklore in psychiatry. There are so many myths and lies in psychiatry. It's pretty astonishing for me, who is a specialist in internal medicine. I never heard of any specialty where there are so many lies as in psychiatry. It's very strange. There was an early double-blind trial where the National Institute of Mental Health investigators and they had not been blinded effectively because these drugs have side effects. They saw the exact opposite of what is actually true when you medicate people with these drugs. Because what they reported was reduced apathy. It's the opposite. Improved motor movement, not at all. Less indifference, totally wrong. So this tells you a lot of how unreliable trials in psychiatry are, that psychiatrists very often see or report what they would like to see. This is a psychological phenomenon. They have failed to live up to their professional responsibility by neglecting to perform head-to-head trials between benzodiazepines and antipsychotics. When I lecture for patients or previous patients and ask them, if you should get admitted next time with a psychosis, what would you prefer, a benzodiazepine or an antipsychotic? Every one of them, so far, has said a benzodiazepine. Then why do we treat them with drugs that are among the most toxic drugs ever invented, apart from chemotherapy? It's not right. In 1989, 35 years after chlorpromazine came on the market, the only 2 trials had compared the 2 types of drugs, and they produced similar improvements. Why hadn't loads of these trials been done? Because the drug industry controls everything. And the new drugs were very expensive, the old ones were cheap, so there was no incentive in showing that the old drugs were equally good or perhaps even better. So these trials were not done, but the psychiatrists could have done them. They didn't. There are now more trials, and there is a Cochrane review of 14 trials that showed that sedation occurred significantly more often on benzodiazepines. These trials are not very good, but the best evidence we have tells us that benzodiazepines are probably better. This is incredible. Since these trials are so flawed, can we trust meta-analysis of many trials in Cochrane reviews, for example? No. By and large, we cannot. There is a huge Cochrane review of chlorpromazine, 55 trials, 5,500 patients. And now look here, the abstract says that akathisia did not occur more often in the chlorpromazine group than placebo. There was no reservation for this statement. Now, akathisia is this extreme form of restlessness where some people say, I want to jump out of my skin. It means I can't sit still. They pace around frantically, perhaps. And this predisposes to both suicide and homicide. It's a horrible condition. How can it be that these drugs cause akathisia? Because antipsychotics cause akathisia. Placebo cannot cause akathisia. So what did we see in these trials? A cold turkey in the placebo group. The placebo group was harmed so much that you couldn't see how dangerous these drugs were. This result speaks volumes about how flawed trials in schizophrenia are. Some Cochrane researchers, they realized this. So they wanted to study people with schizophrenia who had never been treated with antipsychotics before. How can you find such people? They virtually don't exist. So they went for first episode schizophrenia, where no one had been treated before, to avoid this bias. But they found so little, so that what they ended up with was a review of studies where a majority had first episode schizophrenia. They even included second episode schizophrenia, so they were likely already treated. And if the majority had first and second episode, then there must be some who had a third episode or fourth episode schizophrenia. So these trials were still flawed, but what they found was the available evidence does not support a conclusion that antipsychotic treatment in an acute early episode of schizophrenia is effective. Isn't it incredible how difficult researchers can be? Why don't they just say they didn't work? That's what it means. And the next sentence is even more difficult. The use of antipsychotic medications for millions of people with an early episode appears based on the evidence for those with multiple previous episodes. In plain English, these trials are crap, and we don't know what we are doing. We treat these patients with drugs that I believe they would fare better without receiving. But then, how long should we treat them? Many of them are treated for years or for the rest of their lives, unfortunately. What happened after 2 years? Well, more had relapsed when they lowered the dose or stopped the dose than if they continued. But recovery was the main outcome. Who got well? Well, after 7 years, more people had recovered when they had their dose reduced or stopped, 40% versus 18%. And the dose in the last 2 years was 64% higher in the maintenance group, and stopped drug completely at 7 years. 11 had stopped during this period of time in the dose reduction group versus 6. So they got less drug and they fared clearly better. We have other evidence that supports this, that the less you use of antipsychotics, the more likely it is that your patient comes back to life and get a work and get on with life. So these antipsychotics, they create chronic patients. That's what they do. How do we find out if they kill people? Some leading psychiatrists say that antipsychotics actually help people survive. That's pretty far-fetched. Such toxic drugs, how can they help people survive? And then they built their view on very bad research. If we use the randomized trials in schizophrenia to find out if these drugs are lethal, then it's flawed, because we have deaths in the placebo group because of cold turkey. So we can't use the schizophrenia trials. So I went to the elderly with Alzheimer and dementia, where these trials had been tried, because I thought, well, then likely a good deal of these people were not in treatment before, so there was no cold turkey in the placebo group. So what did that show? Well, for every 100 people treated for a few weeks, there was one additional death on drug compared to placebo. This is damning evidence that we kill a lot of people with these drugs, and that was only throughout some weeks. Considering the huge weight loss that many people acquire, and they develop diabetes and heart problems and so on, it's very difficult to imagine that these drugs save lives. They don't. They kill a lot of people. And they do a lot else. They cripple people. They lead to irreversible brain damage that can start pretty quickly and in a dose-related fashion. The longer and the higher doses, the worse. Few people get back to normal life compared to if you hadn't treated them with drugs. You become dependent on virtually all psychiatric drugs, so you can get abstinence symptoms if you stop suddenly. And you can get psychosis even if you're still on the drugs, because you change the brain in such a way that you can get what is called the supersensitivity psychosis. And that's typical for many other psychiatric drugs, that they can actually create the diseases they were supposed to work for, or even worse diseases. So they are really double-edged swords that doctors have extreme difficulty handling. They can't. So let's go back to the ethics. Is force ethically defensible? No. A few hours or days of disturbed behavior are treated as a cause for a lifetime sentence to a drug treatment, and psychiatrists in training will hardly ever see a patient who is not already snowed under with drugs, and therefore get a wrong impression both of the patient and his strengths and the potential for cure without drugs. So typically when patients have strange movements and tics and salivates and so on, these are drug effects. But many people believe this belongs to schizophrenia. That's a disease effect. It's not. Some psychiatrists feel they cannot live without forced treatment. Most of them feel that, but they should think about that the patients cannot live with it. They actually die from it. That's far worse. Only soldiers at war and psychiatric patients are forced to run risk against their will that might kill or cripple them. But soldiers have chosen to become soldiers. Psychiatric patients have not chosen to become psychiatric patients. So this is deeply unethical. And as we all know, power corrupts. And the power imbalance in psychiatry is extreme. So there is a high risk that forced treatment is being used to benefit the staff rather than patients in order to make their work less stressful. We know that this happens a lot. I have estimated antipsychotics have killed hundreds of thousands of people and have crippled tens of millions. It's really gigantic. Some patients who were killed have begged what they call their torturers not to get the drugs. And very few have been investigated for slow metabolism, which can increase the risk of death. Quite many people have different metabolism from average, slow, intermediate, or fast. Here is a heartbreaking story of a Danish girl written by her mother, how psychiatry killed her daughter at age 32 after her 14-year career in psychiatry. She was a slow metabolizer. Her mother begged the psychiatrist to have a test done, which he refused. When Louise's best friend suddenly dropped dead on the floor at the hospital in Denmark, Louise said, "I'll be next." She was killed 6 months later. At one point during all that, she asked her mother, "Mother, do you think it's better in heaven? It is so cruel." And very few will believe in forced treatment after having read this book. You will have tears streaming down your chin if you read this book, so I can recommend this for you. The psychiatrists didn't listen, not even to their own staff who knew Louise much better than they did. And they declared that she was seriously ill and should have even more drugs when the staff said she's doing fine. They consistently blamed Louisa and her mother for everything. It was never the precious pills, and certainly not themselves, that were at fault. This is quite typical as well. And they increased the dose when it should have been decreased or stopped altogether. Louisa didn't tolerate the drugs, and she was aware that they would likely kill her. Post-mortem, the system congratulated itself for its first-class homicide. Louisa had received the highest standard of specialist treatment. That's what we say when we kill people in psychiatry in Denmark. Cause of death, unknown. The officially accepted term for such death is natural death. How natural is it that a 32-year-old girl suddenly dropped dead? We know that psychiatric hospital contact is pretty fatal. We know that from a large Danish register study of 2,500 suicides. The closer the contact with psychiatric staff, which often involves forced treatment, the worse the outcome. The suicide risk is 44 times higher for people admitted to a psychiatric hospital compared to those who don't receive psychiatric treatment. And then you will, of course, think, isn't that natural? Those who are most ill get admitted to hospital and they kill themselves. That's not because of a bad environment at the hospital, but actually most of the potential biases in this study favored the null hypothesis of there being no such relationship. So this study is pretty strong. And there was an editorial that said it's entirely plausible that the stigma and trauma inherent in psychiatric treatment, particularly if involuntary, might cause suicide. People in my country are still told, not always, but sometimes, schizophrenia is a chronic, lifelong disease and you need to be drugged lifelong. And then they leave hospital and have no hope. Is it strange that some people kill themselves at this point when they also suffer from horrible side effects? I don't think so. And schizophrenia is not a chronic, progressing disease. People can get cured from schizophrenia. So now we come to Alaska, because the Alaska Supreme Court has decided that the government cannot drug someone against their will without first proving by clear and convincing evidence that it is in the best interest of the patients and there is no less intrusive alternative available. I have told you about benzodiazepines. That's less intrusive. There is always less intrusive alternatives available. And Jim Gotzsche, himself a previous patient, used scientific evidence to convince the judges. In another case, the court decided that if the alternative is feasible, the state has either to provide it or let the person go. Jim has also noted that psychiatrists with a full understanding of the trial judges regularly lie in court to obtain involuntary commitment and forced medication orders. I got that experience yesterday. The petitions I saw were full of lies. It was unbelievable. We can discuss that later. Now, the legal issues are, for example, the European Convention on Human Rights that is about prohibition of torture. No one shall be subjected to torture or to inhuman or degrading treatment or punishment. And we have a committee for the prevention of torture that travels around and visits psychiatric institutions and write reports with criticism. And they say that patients are often restrained, usually mechanically, in belts as a sanction for perceived misbehavior or as a means to bring about a change in behavior. That's not allowed. Where physical restraint is necessary, it should in principle be limited to manual control, that you fix the patient like this. Talking to the patient or calm him or her down is the preferred technique. And Peter Gotzsche from New York, in particular, has shown how effective this can be. You can talk people down, and you need to be kind to them and respect them. Then you rarely need drugs. And if the patient wants something to sleep on, a benzodiazepine will do it. And then the excuse that mechanical restraint is good because then it liberates staff for other tasks, that's wrong. It requires more, not fewer medical staff, because you need constant surveillance. Some people die when they are mechanically restrained. Not many, but at one point it was 100 per year in the United States. Psychiatric patients should be treated with respect and dignity, and in a safe, humane manner that respects their choices and self-determination. That certainly doesn't happen here in Alaska. And the torture committee all too often finds that fundamental components of effective psychosocial rehabilitative treatment are underdeveloped or even totally lacking. So it's all about drugs or electroshock or bells. And that the treatment provided to patients consists essentially of pharmacotherapy. There isn't a single randomized trial that has compared seclusion or mechanical restraint with no such intervention. But as I said, these measures can be fatal. And electroshock is fatal in around 1 in 1,000 that are treated. We have a human right to equal recognition before the law. It should apply to everyone, also to people with mental disorders, but it doesn't do so currently. But the Universal Declaration of Human Rights, International Covenant on Civil and Political Rights, United Nations Convention on the Rights of Persons with Disabilities, ratified by virtually all countries, apart from the United States, Jim Gotzsche told me. It's the only country in the world I know of that hasn't ratified this convention. That's your country. So this convention says that member states must immediately begin taking steps to realize the rights by developing laws and policies to replace regimes of substitute decision-making. We will decide what is good for you by supporting decision-making which respects the person's wishes, the person's autonomy. People have the right to be free from involuntary detention in a mental health facility and not to be forced to undergo mental health treatment. It's very clearly formulated there. So forced treatment is a violation of the right to equal recognition, you already heard that, and an infringement of the rights to personal integrity, freedom from torture, freedom from violence, exploitation, and abuse. And as everybody knows, violence breeds violence. So when patients are violent in wards, it's often because of the inhumane conditions they have experienced. It's not their disease. It can be, but it's usually not the reason. So it goes on like that this is a violation found all over the globe, despite, this is important, despite empirical evidence indicating its lack of effectiveness. So it doesn't work. And the views of people using mental health systems who have experienced deep pain and trauma as a result of forced treatment. So we introduce a lot of harm for no benefit, virtually no benefit. It's very little, and very little compared to the harm. So those who are the first ones to meet the patients, first responders, they must be trained to recognize people with mental disabilities as full persons before the law and give the same weight to their complaints and statements as they would have for anybody else. That doesn't happen today. Unsoundedness of mind is not a legitimate reason for the denial of legal capacity. I saw that on all the forums yesterday. The patient is unable to give informed consent. That is simply not true. Very few psychiatric patients are not able to give informed consent, but it's used as an excuse for applying force. And the concept of mental capacity is highly controversial in itself. It is not an objective, scientific, and naturally occurring phenomenon like elephants in Africa. Mental capacity is contingent on social and political context, as other disciplines, professions, and practices which play a dominant role in assessing mental capacity. And who assesses mental capacity? The psychiatrist, who has an enormous conflict of interest and believe in these drugs and all the other things. The patient is defenseless. Where is the independent observer here? Gone. Then we have these advanced directives that are very important according to the convention. So people should, if they state their will and preferences before they get admitted to hospital, they should be followed, they should be respected. The point when they enters into force and ceases to have effect should be decided by the patient and not by the staff. If you cannot find out what the patient really means, because the patient is deeply disturbed, it is the best interpretation of will and preferences must replace, we know what is best for you. That's how it is today. We must try to interpret, and we can ask the relatives. What treatments do we have in psychiatry that means that if we don't force the patient into a hospital, the prospect of cure will be substantially and significantly impaired? We don't have such treatments. It's fantasy, it's pure wishful thinking. In Iceland, the same. They call for the police, and the police stay at the psychiatric ward. Same laws for everyone, no discrimination there. I learned today that in the United States, you can force such a person to receive blood transfusions. We don't understand that in Denmark. We value personal autonomy higher than this. If people decide for themselves, let them decide. Some people do very dangerous things. They drive a motorbike without helmet and as fast as they can and all that, and some die. People do a lot of things that kill them. We have to accept that. The only drugs that can be given without permission are also some of the most dangerous ones. And I have estimated in my book, based on the best science I could find, that psychiatric drugs are the third major killer after heart disease and cancer. They kill an enormous amount of people. And then there are the colossal misconceptions. It's a common law assumption that if a person is unable to give consent, the health professional acts in accordance with what she herself would have preferred. But we cannot assume that a severely psychotic person would want psychotropic drugs. or that she is unable to understand what is being proposed or its consequences. For example, she might decline drugs because of previous experience of serious harms. A patient can be floridly psychotic. That doesn't mean that they don't know what it means to take an antipsychotic drug and want to not to be treated. It's again a violation of human rights. And laws about forced treatment surely build on the harmful misconception and that antipsychotics have a specific effect on psychosis, which is good for people. They don't have such an effect. Now, in 1975, patients in the United States took their fight to courts and battled for their rights, and at the same time, Soviet dissidents smuggled out manuscripts describing neuroleptics as the worst sort of torture. It's rather difficult to explain how the same substance can be a poison in one country and a helpful remedy in another, particularly as the poison was used as forced treatment in both countries. We can do a lot instead of force. Assertive communication rather than intervening too late in turmoil. Basal exposure therapy, if people are very afraid of something, like if they have a phobia, you can expose them to it gradually. Offering drug-free alternatives, that will be introduced in Norway now. So this is a way of getting rid of forced treatment, because if you can decide, I want to come to a psychiatric department where I won't receive drugs, then we are already on our way of banning forced treatment. That's very good. I tried to get political backing in Denmark for the same, and there is interest in this. And few people who need being calmed down will refuse drugs, but let them decide themselves. Always have plans for tapering off drugs. They virtually never exist, and the psychiatrists have never learned how to do it. So typically, they lower the dose to only 50%, and then people get very bad. You need to take very, very little, typically only 10% of the dose, and then wait for a while. No one ever taught them, but everybody taught them to use drugs. The drug industry, but how to stop them? No. Psychotherapy works for schizophrenia. We found that out 2 years ago because some people refused to be treated with antipsychotics, and then a trial was done on psychotherapy. Of course it works. And if you try to find out why did that patient have a psychosis at this point in time, what happened to you earlier in your life, it is so incredibly important to find this out. But modern day psychiatrists, they rarely have time of taking, they have time, but they prioritize differently. They don't take the full story. I hear stories from patients that have been zombies for 10 years until they met a good psychiatrist that actually took a history and then found out what was wrong with them and started to take them off drugs, and they became healthy. Open dialogue is invented in Finland and Lapland, which means that if a patient becomes psychotic, you involve the family within the first 24 hours, and you use drugs very, very little. You talk to people, you use empathy and love, as Peter Gotzsche would say. You respect the people. And then there is the good cop and the bad cop. If you have been a cop and have used force, it's impossible to change that role the next day and now pretend that now you're a healer and want to do the best for the patient. You can't do that, really. Maybe you can sometimes, but usually not. This is why psychiatrists should not act as police officers. And violence breeds violence, as I said. Then there are the community treatment orders. I heard about that today, that even when you get out of hospital, then you are not free from these drugs. So you can get forced treatment still, and if you don't take your tablets, you can get an injection. There is a Cochrane review, and there was no difference in service use or in anything else. And in the UK, it was hoped that community treatment orders would lead to fewer hospital admissions, but the admissions increased. And there was great variation in these orders. Some areas discharging half of the patients with treatment orders, and others not at all. So some psychiatrists just felt, now it's too much. We won't use this. This is unethical. And there is a huge risk of abuse with community treatment orders, a catch-22 situation. Now, if a patient's distress is considered manageable, the professionals may well argue that the setup is working and should be continued. But at what point should it then be stopped? And what if it doesn't work? Then forced drugging is often increased, causing even more misery and more death. Mental Health Act police officers. We cannot intervene as long as the patient is conscious. We're not allowed to do that. We can do that without forced treatment, without these damn drugs. And you should also notice that if we abandon forced treatment in psychiatry, it will produce vastly more good than harm. And we can have a psychiatry without force. This has been demonstrated in Iceland, where a psychiatrist burned the shackles in 1932, and they haven't been used ever since on Iceland. Norway, Akershus, that's close to Oslo, doesn't have a regime for rapid tranquilization, and it has never needed one in the last 20 years. That's up in Norway. What happens in the States and in Denmark when psychotic patients come in the door? Immediately that poor guy is treated with an antipsychotic. That's the standard. In Norway, they don't have a regime for this. That's pretty amazing. And in London, the psychiatrists waited on one hospital an average of 2 weeks before they did anything in terms of drugs on newly admitted people. And most people chose to take some medication, often in very small doses. They decided it themselves. So it's very well possible that it was respect, time, and shelter that helped the patients, not the sub-treatment threshold doses. And in northern Italy, force is not used. The head of psychiatry argues that you have to completely prohibit coercion, since the employees would otherwise use it and not develop other approaches that means that coercion is not necessary. And I read in the Norwegian news, no, that was the official TV broadcasting homepage. I read yesterday that the psychiatrists were confused in the whole of Norway because the minister had told them they should now provide medicine-free departments. Their confusion was, but what should we then do? We always treat people with drugs. Help, we don't know what to do without drugs. That's pretty scary, isn't it? But now they have to do it because the minister tells them. A Northern Ireland priest and writer, he wrote something very interesting. Of all tyrannies, the tyranny sincerely exercised for the good of its victims may be the most oppressive. It would be better to live under robber barons than under omnipotent moral busybodies. The robber baron's cruelty may sometimes sleep. His cupidity may at some point be satiated. But those who torment us for our own good will torment us without end, for they do so with the approval of their own conscience. This is very central to what I want to achieve with psychiatry. Now, we have our problems. Only 2 years ago, the Danish Ministry of Health issued a license to kill. It allowed psychiatrists to use extraordinarily large doses for forced treatment and said that this applies especially to patients who have been in prolonged treatment and where smaller doses have been tried without a good therapeutic result. But these are the patients who should have their drug withdrawn. Exactly opposite. Giving more of what was already not working doesn't help. It kills. Rest in peace. Forced treatment. Thanks, not the patients. So, prescription drugs are the third leading cause of death. There are several studies that show about the same. Some people say it's the fourth leading cause of death. It doesn't matter. We kill a lot of people with our drugs. And I described why in this book I published, Deadly Medicines and Organized Crime, How Big Pharma Has Corrupted Healthcare. So we have created a society that looks like the man at the bottom, all about drugs. And it is really an epidemic. 8 million daily doses in Denmark, and we are 5.5 million, so everybody can get more than one drug every day from they are born till they die.
But of course, some get more drugs than others. And 1 of 8 get at least 5 drugs every day. And these people are mostly the elderly who tolerate drugs most poorly. That doesn't make any sense. And just to take one of them, arthritis drugs, 1 of 8 Danes get one every year. And they're highly lethal. When I worked in the drug industry many years ago, I did research on naproxen, and one day I read the package insert, and I said, my goodness, a drug that can kill me in so many different ways, I will never take it for the rest of my life, any anti-arthritis drug, and I haven't done that. So these drugs are used for virtually everything, back pain, knee pain, migraine, whatever you can think of. It's absolutely insane. The companies cheated with their data. Merck, as you know, concealed cases of myocardial infarction and even death with rofecoxib. And Pfizer denied that their drug caused heart attacks at an FDA hearing in 2005, despite they had unpublished evidence to the contrary. And they still called the evidence inconclusive in 2009 when they recruited people also in Denmark to take part in a trial. They said, we don't know if it causes heart attacks. They did. So by 2004, Vioxx had likely killed 120,000 people and Pfizer's drug 75,000. It's not only these drugs. Now we all know that diclofenac and ibuprofen, which can be bought over the counter in most countries, they also double the risk of heart attacks. What do FDA do about this? Well, the FDA approach to safety is virtually to disregard it. The FDA believes there is no risk that cannot be managed in the post-marketing setting, and the European Medicines Agency, unfortunately, copies the FDA. They say the same. So they say, we can't be 95% certain that this drug will kill you, so therefore we will allow it on the market, assuming it doesn't. Imagine if you were a doctor and give a drug to a patient and say, I'm not 95% sure it will kill you, so go home and take it, and if you wake up next morning, tell me how it went. It's David Graham, Associate Director of FDA's Office for Drug Safety. He has worked there for more than 40 years, who said that. So the FDA approved Vioxx because it lacked complete certainty that the drug increased cardiovascular risk, although this was known all the time based on the mechanism of action. We knew this drug causes thrombosis. The FDA didn't care. The EMA didn't care. So it's a bit like I'm going to prescribe something that works like aspirin but costs much, much more. If only doctors were more honest, they wouldn't kill so many people. Then we also have psychiatry. I got involved in that 9 years ago because someone wanted to do a PhD with me. And antidepressant drugs, we take so many in Denmark so everyone can be in treatment for 6 years of our life. This is totally insane. And sales are closely related to the number of drugs on the market. So it's marketing pressure. It's not evidence-based medicine. Every time a new drug comes on the market, you have a new sales force that travel around to doctors, say, use SSRIs for everything. And this is what they do. Divorce, poor marriages, husband drinks too much, husband is worried not to earn too much money for the family, failed a test at school, nervous to go to exams, whatever. Yes, we have a happy pill for you. And even husbands who beat up their wives, then you can give a happy pill to the wife, and you can give one to the husband who is violent. This has happened. It happens in my country, and these drugs increase the risk of violence. So wonderful. Give these violent males a drug that increases the risk he will beat up his wife. It's absolutely incredible what happens. Studies have shown that in many, many cases, there is no good indication for using these drugs, but still doctors do it, and it's generally general practitioners who do this. We can't find anything wrong with you, so we are going to treat you for symptom deficit disorder. This is about where we are with antidepressant drugs. We cannot practice evidence-based medicine when we don't know about the deaths. And the deaths are missing to a huge extent. Trial registers were compared with the first standalone journal article, and 62% of deaths and half of the suicides, they were simply missing. They were gone. They were not in the journal articles, and these were antipsychotics an ADHD drug, and 2 antidepressant drugs. So doctors think that psychiatric drugs are much more safe than they really are. So I published a book about this last year, where I concluded that psychiatric drugs alone are also the 3rd major cause of death after heart disease and cancer. But I will give you the basis for my views in a minute. And I also calculated that psychiatric drugs kill 500,000 Americans and Europeans every year. Drugs that affect your brain are dangerous for the elderly because they can lose balance, fall, break their hip, and 1/5 will die when they break their hip. And here is the best study I could find from BMJ. A cohort study of people at least 65 years of age showed that these drugs lead to falls. And for every 28 people treated for 1 year, there was 1 additional death. That's a death rate of 3.6%. That's very high. There are other studies that are not so well done, where there's much more noise, so the death rate was lower. This is the best one I could find. And also, middle-aged people who were completely normal have committed suicide or homicide or both on antidepressant drugs. So I have come to the conclusion these drugs are not safe at any age. These cold turkey symptoms can be for antidepressant drugs, psychosis, akathisia, which is an extreme form of restlessness that predisposes to violence, emotional blunting, I don't care much about myself or others, and such things. And we know, for example, for antipsychotics that this design is very lethal. 1 in every 145 patients who entered the trials died, but none of these deaths were mentioned in the scientific literature, and the FDA didn't require them to be mentioned, so they were just gone. So I thought, well, look to the old people. Maybe they didn't get an antipsychotic drug before they were randomized. So that I did. So there are some trials in patients with dementia, and for every 100 people treated, there was 1 additional death. And these trials were short-term. And as deaths are usually missing from published trial reports, it might be worse than 1 in 100. So yes, antipsychotics kill people, but some psychiatrists will tell you that they actually make people survive based on very poor observational studies. Don't believe in them. They kill people. Now, then I tried to estimate how many people are killed by psychiatric drugs. And for antipsychotics, you just saw my estimate, 1% in short-term trials. Benzodiazepines, also the best observational studies I could find, 1%. Antidepressants, it was 3.6%, but I wanted to be conservative, so I said, well, let's say 2% and not almost 4%. And what I got out of that, because so many people are in treatment with antidepressants all over the world, we kill 3,693 people in Denmark every year. And when I multiply that, it comes up to 500,000 in United States and Europe. Here is one example of how unreliable the evidence is. Suicides. Suicide risk is far worse than what the FDA has reported. The FDA reported 5 suicides in 50,000 patients on active drug. That's 1 per 10,000. But in some of the trials I have looked at, there were more suicides, 9 in just 7,000. And these trials were included in the big meta-analysis, and 5 on another drug, paroxetine. So these 2 drugs made 14 suicides. So already there, 9 suicides are missing. How can you get away with suicides? No problem in evidence-biased medicine. No problem at all. Thomas Logren, the FDA guy who was chairing the big meta-analysis that found very few suicides, 5 years before he published his own review where he then found more suicides based on the same material, 10 per 10,000. That's really something. The same guy published 10 times as many suicides 5 years earlier, but when when it was a burning issue for the FDA and the drug industry, then the suicides went away. So my conclusion is there's likely to have been 15 times more suicides. That's an error of 1,400%. And one of the smart ways of getting rid of suicides is only to include suicides that occur up to 24 hours after the randomized phase is over. What happens after 24 hours? People get a cold turkey and some kill themselves in akathisia, okay? What happens in clinical practice? In clinical trials, psychiatrists do all they can to have compliance with the drug. What do people do in practice? They may go for a weekend and forget their drugs. They may forget to take it on work. So in clinical practice, if these trials are to reflect clinical practice, we must, of course, include what happens after 24 hours. And if you include that, you will get many, many more suicides. I have that on some other slides I won't show you today. And there were lots of other biases. People who got agitated and developed akathisia were put on benzodiazepines to calm them down. What does that mean? Less risk of suicide. That's not what happens in clinical practice when you forget to take a dose to work. In all these trials, only people at low risk of suicides were recruited. Now, if the drug industry had believed that these drugs prevent suicide, they would not have found people at low risk. If you have a cardiovascular drug that helps people survive, you will not study it in footballers, would you? You would study it in old people who get myocardial infarction. So the drug industry didn't believe in what they told the public. They knew perfectly well what the truth was. So these drugs are pretty deadly. Do they have any benefits? I actually doubt that. The effect is measured on very subjective scales like Hamilton, so it's important the studies are adequately blinded, which they are not. And there is a very important Cochrane review where people put something in the placebo in order to have a better blinding. Atropine gives you dry mouth, constipation, blurred vision, and so on, just like the drugs. And what happened here, 9 trials and so on, I have recalculated the effect. That's 1 on the Hamilton scale. That's absolutely nothing. Despite all these biases that the trials are not adequately blinded, what do the patients say in these trials? Well, the psychiatrists say that the drugs work, standardized mean difference 0.25. The patients say they don't work in the same trials. That's a Hamilton of only a half. And also the old drugs, it's about the same. So we're not treating psychiatrists, we're treating patients. And they say the drugs don't work. And here is another study, week by week, severely depressed, mildly depressed. It just takes a little longer if you get placebo, even though these studies are not adequately blinded. So maybe you should stop your drugs. Use drugs as little as possible. A life without drugs is possible. For many of us, even those of us who are age 65 plus. And then the huge death toll translates into a general practitioner on average kill 1 patient every year with drugs. Most of them didn't even need. You don't need arthritis drugs usually. You can do nothing or use paracetamol. You don't need antidepressant drugs. You need at most 2% of the psychiatric drugs we use today, and then many more people would survive and be happier. So what the hell are we doing? Thank you.
What we do to children with psychiatric drugs nowadays, I think, is a crime. It's a crime against humanity. These small developing brains shouldn't be treated with alcohol. Parents wouldn't do that. They shouldn't be treated with marijuana, which is also a dangerous substance, or street drugs, cocaine and so on. So why on earth do we treat so many of them with psychiatric drugs? Some ADHD drugs, they are amphetamine. So if you get it on prescription, it's all fine. If you buy it in the streets, it's illegal. It doesn't make any sense. These drugs are generally harmful for the children's brains. The benefits are usually quite doubtful. If you ask me, I think we should not treat children with psychiatric drugs. We make matters worse. by doing this. It would be better if we didn't treat them at all, compared with what we do today, where we treat so many of them with psychiatric drugs. We are harming children on an enormous scale. And the very sad thing is that when they then get side effects, they can get an additional diagnosis and more drugs. Typically, they can be told that now you are bipolar. And then a psychiatrist can tell the parents, oh, that's good. This Ritalin drug unmasked an underlying bipolar disorder that we would not have seen were it not for this drug. I mean, this is horrible. If you have a patient that comes in from the street and is psychotic because that patient has abused whatever, cocaine, LSD, marijuana, you don't tell that patient, oh, great, you took marijuana because now I can see that you are schizophrenic. You don't do that. You don't even come up with a diagnosis. You wait for some days to see, is there a normal person here when that person is not under chemical influence? So it should be illegal to come up with additional psychiatric diagnoses in people whose brains are already under influence, whether it is by alcohol, LSD, psychiatric drugs, whatever it is, amphetamine. You shouldn't do that.
Professor Peter Gotzsche. Now, Peter is a great titan in the clinical research community, least of all for co-founding the Cochrane collaboration in 1993, and he is now director of the Nordic Cochrane Centre. He's also Professor of Clinical Research Design and Analysis at the University of Copenhagen and has published over 70 papers, and he's also published in the big 5 medical journals, which very few people have actually managed to achieve. And he's been cited a staggeringly 15,000 times. He is author of the following books: Rational Diagnosis and Treatment, Mammography, Screaming, Deadly Medicines and Organized Crime, and his most recent book, Deadly Psychiatry and Organized Denial. Peter Gotzsche.
It was difficult to find the right title. I had 18 different proposals before I settled on that one, which I feel is the right one. It's that serious. Imagine a boy whose sweetheart left him. How do you think his next 14 days will be like? Miserable. He can't sleep, he can't eat. Bingo, you have a diagnosis of depression. What happens next? He will likely get a pill if he looks up a GP or a psychiatrist. Now, one of the things that have been criticized a lot about DSM is how they look on bereavement. In the DSM-3, you were allowed to feel sad for 1 year before you got a diagnosis of depression. Then it became 2 months, and then 2 weeks. So I wonder, why not 2 days in the next edition? And of course, doctors are not like that. Do you really think that they sit with a sad person and say, well, let me look up in the DSM? No, you need to wait another 10 days before I can give you the pills. You will get the pills immediately. That's how it works. And why cannot the psychiatrists get enough? I hear them complaining about they have too much work to do. Yes, because they turn a lot of temporary problems into chronic ones with their drugs. Of course they have too much to do. If they use drugs far less, I think we would have enough psychiatrists. When I tell psychiatrists that these are poor drugs, then they say, well, they are perhaps not that fantastic, but then the patients benefit from the placebo effect. This is not true. Because to know what the placebo effect is, you need what? An untreated control group. If you don't do anything, most people would feel better after some weeks. That's not a placebo effect to do nothing. So what happens in a placebo group is not a placebo effect. Very few people understand this elementary methodology. It's not. But is the effect correct? No, it's not. The effect is measured on highly subjective scales like the Hamilton Depression Scale. And there are other meta-analyses of these trials. They all show about the same. What about the old drugs? And in adults, not children, like amitriptyline, what did the psychiatrists say? Again, an effect of 0.25, which is really nothing. And what did the patients say? They don't work at all. Here is an important meta-analysis of two drugs, fluoxetine and venlafaxine, done by an American statistician who receives a lot of industry money and produces some very strange research again and again, not always completely honest. But here he wanted to see how quickly do patients improve when they get antidepressant drugs. And what you can see is that they all, on average, they were severely depressed because they had a Hamilton of 21. How long did it take before they came down to about 13, which means mild depression? Well, around 4 weeks or a little longer on drug. How much longer did it take if they got placebo? About 1 week. These trials were not adequately blinded. If they had been adequately blinded, the placebo group would have come to the same point in a couple of days, a matter of days. Is it really worthwhile to use drugs with a lot of harms to gain a benefit of a couple of days before you arrive at the same level of depression? I think definitely not. So everything I have, not everything, of course, there's a lot of flawed research, but the good research I have looked at tells me the same story. These drugs likely don't work for depression. It's all a fata morgana. Do you know what that is? No, it's out in the desert when you think there is a lake, but there is nothing. Mirage, that's French. I didn't know English people could speak French. So my scientific conclusion is inevitably these drugs don't work. What we see are mirage, not miracles. And what about if you ask the patients, if the drugs really produce more benefit than harm, then the patients should stay on them more than they stay on placebo. That's logical. They don't. They leave the trials as quickly on drugs as on placebo, so they don't work again. After only 2 months, half of the patients have stopped taking the drugs. And this is in trials where psychiatrists, often on an industry payroll, they have an incentive of telling the patients, you must stay on the drug, because if they don't, they might not get paid. Because sometimes the payment is dependent on that they carry through the whole trial. And what did the psychiatrists think about antidepressant drugs when they first came on the market, the newer ones, I mean, the SSRIs? Well, the first big one was Prozac, which the German drug regulator deemed totally unsuitable for the treatment of depression. And when Eli Lilly's director in Sweden presented fluoxetine for Swedish psychiatrists, they laughed him out. How can you ever think you can get this terrible drug approved? But then he found out who the guy was who was going to write a report to the Swedish authorities about Prozac. And already at their second meeting, that guy, Anders Forsman, he said how many dollars it would cost to write a positive report about a drug he had laughed out some weeks earlier. This he did. And he did a great career after this corruption. He became assessor for the country of Sweden in legal matters, in psychiatric legal matters. So you can get away with it. Many doctors and patients think antidepressants work, but why is that so? It's because you are not well. You do something, some weeks later you are well. Then you make the error of thinking that's because of the drug. You confuse the spontaneous healing that takes place. So when psychiatrists in debates with me say, according to my clinical experience, these are very good drugs, I think your clinical experience is worth absolutely nothing because you don't know what would have happened if you hadn't done anything. There's no control. You can also ask, Hamilton scale has been much criticized. Why do we treat people with depression? To get them back to work and save relationships and all that sort of thing. Do they work on that? There are thousands of trials of antidepressants. I have never seen such a positive outcome in any of them. So either it has not been studied, or it was, and it was pretty negative and buried in company archives. What about sexual problems? They actually cause sexual problems in half of those treated who had no sexual problem before they started an antidepressant drug. Does that save intimate relationships, that you destroy people's sex life? I don't think so. An FDA scientist found out that the drug companies are routinely putting the blame on patients and their so-called diseases and not on the drug. For example, when females couldn't get orgasm, it was coded as female genital disorder. It's your problem, it's your fault, not our pill's fault. And Eli Lilly said only 2% become sexually disturbed, but there is good research. Here is a Spanish study. 60% of people who had a normal sex life became sexually decreased libido in 60% of the patients, delayed orgasm or ejaculation in 60% of the patients. So actually the drugs do something to prevent a man from having ejaculation. That's pretty strong stuff. Erectile dysfunction or decreased lubrication. When I lectured for Australian child psychiatrists half a year ago, one of them said he knew 3 boys who couldn't get an erection the first time they were about to have sex. They were on antidepressant drug. All of them tried suicide after this experience. So what we do to people is really serious. How could they think it was the pills? They thought it was themselves that was the problem. That's what patients typically think. Some of you in here will know that it can take years, and some of you will never succeed. You will be hooked on the drugs for the rest of your lives. I had a PhD student who found out that the withdrawal symptoms were actually pretty much the same for benzodiazepines and SSRIs, and they were not described as dependence for SSRIs. Why? Because the American psychiatrist on company dollars introduced a new version of what does it mean to be dependent just before Prozac came on the market. It must have been worth billions for the drug companies. So now I hear psychiatrists telling me they don't become dependent on SSRIs, they just need to be educated that this is not a problem. That's what psychiatrists generally say. And then they also say, you don't become dependent on SSRIs because dependence means that you should crave higher and higher doses. And then I say, great, then no one is dependent on cigarettes because they smoke 20 every day and have done that for years, no dependence there. Great. We can stop smoking tomorrow. For patients knows what it is about. When you ask patients, half of them will tell you it's difficult to stop SSRIs. Now, what does the UK drug regulator say? Oh, they're not addictive, they said 10 years ago. But the same year, the WHO actually published a report that noted that 3 SSRIs, fluoxetine, paroxetine, and sertraline, were among the top 30 highest-ranking drugs for which drug dependence had ever been reported. And now we're including morphine and other opiates. In the same year, GlaxoSmithKline, in small print, revised its previous estimate of the risk of withdrawal symptoms from 0.2% to 25%. That's a 100 times increase. They surely didn't publicize this and say, sorry, we are wrong, we have fooled you. It was in small print in the patient information. If you look at the other drugs first, then you can see the withdrawal symptoms. They didn't know when the placebo period came, of course. This was blinded. So the withdrawal symptoms included worsened mood in about 1/3, irritability 1/3, agitation 1/3. What does this mean? Agitation can be a euphemism for akathisia. What does akathisia do? It increases the risk that patients commit suicide and homicide. It's very, very serious. So what you see here is proof that withdrawal symptoms include depression. Then doctors will tell you that you are still ill or your depression came back, so now you have to go on forever on these drugs. But how can you distinguish between an abstinence depression and a true depression that would have occurred at any rate? You can do that very often by giving people the full dose. Then, within a matter of hours, many people will feel considerably better. You remember the curve I showed you before? It takes weeks before people become better. So if they become better in a matter of hours, it's a false depression. It's caused by the drug, as Robert said so eloquently. It's not caused by your disease. It's the drug that causes this. I got this data from Finland. If you put 100 people on an antidepressant drug in Finland, then 5 years later, almost half of them are still on an antidepressant drug. Not necessarily the first one, because if you're still feeling bad, then the psychiatrist might say, then we'll try another one. Although that won't help either, because none of them work. But that's what people do. And then what does this mean? In the old days, when we didn't have these terrible drugs, a depression didn't last that long. It didn't last 5 years. It lasted some months, and then not very many got a return of a depression within the next year or two. So what this curve illustrates you so beautifully is, I'm sorry for saying this, legal drug addiction. That's what this curve means. And about half of the patients have been told, sometimes 80% have been told about the chemical imbalance, and you know that this is all wrong, so I don't need to say more about this. What about the ultimate outcome that we want to prevent when people are depressed, namely suicide? Do they work for this? No, they don't. The FDA asked the manufacturers to go through their files and report to them the number of suicide and suicide attempts, suicidal thoughts, and so on. And when the FDA published their internal report, they said that antidepressants increased suicidal behavior till age 40, but these data, when they were published, they looked much better for the drug industry. Because now the FDA said, well, it's only risky up till age 25, and after that it's fine, you are on the right side of not harming people. So do they stop harming people at your 25th birthday? Of course they don't. And these data are completely wrong, and I will tell you why. Now, in the FDA's big analysis, there were only 5 suicides in 50,000 patients. That's 1 per 10,000. I found minor materials on drugs that were included in the FDA analysis where there were far more suicides. For example, you can see 9 suicides in just 7,000 patients on fluoxetine. That's 13 per 10,000. Up here, 14 on fluoxetine, 17 on paroxetine. And even worse, the man who was in charge of FDA's big analysis, Thomas Logren, he said in 2006, there's only 1 suicide per 10,000. That's the first line up there. But 5 years earlier, the same man went into the trials in FDA's possession and now reported 10 per 10,000, namely 22 suicides in 22,000. I mean, how can the same man report only 1/10 the number of suicides 5 years later? Because the FDA took great care not to embarrass the drug industry. They told them to go back and look what they could find, but the drug industry had already cheated on the FDA earlier. So this is like telling a criminal, go back to the scene of the crime. We won't send any police detectives. Just tell us what you find. Then come back and report to us. We won't check you. We'll believe you, of course. You're an honest person. That's what the FDA did. So I think there's likely to have been 15 times more suicides on active drug than the FDA reported. That's a pretty big error, 1,400%. And many suicidal events had been coded as something else, like admission to hospital or emotional lability, or left the trial, but the poor guy was going to kill himself, but we didn't learn about it. Only people at very low risk of committing suicide were recruited for the trials. Now, if the drug companies truly believed that these drugs protect against suicide, do you think they would have had this clause, no, we won't have anybody who is at risk of suicide in our trials? They wouldn't. Namely, sertraline, we're not talking about children. Everybody knows that these drugs are dangerous for children, but many psychiatrists think that they protect against suicide in adults. They don't. Now, this is in adults, sertraline, suicides and suicide attempts. The FDA analysis that only looked at events up till 24 hours after the randomized phase stopped, what did they find? A little decrease in suicidality, not much, and not significant. Now, when Pfizer looked at their own trials, it looked far better. Now, our drug halved the risk of suicide or suicide attempt. Great. But Pfizer was a bit careless because they also looked at what happened if we look at up till 30 days after they came off the drugs. Oh, oh, that wasn't good because now sertraline increased the risk of suicide by 50%. Independent British researchers that had access to the data at the drug regulator also found that sertraline seems to increase the risk of suicides in adults. It wasn't quite statistically significant, but it was a doubling. You should not worry about whether things are statistically significant. I mean, one person that falls out of an airplane and dies, that's not a statistically significant death, it's just one. When we look at harms, we should forget about these p-values and statistical significance. We should look at what do the point estimates, what story do they tell us? Now, David Healy had access to company files because of court cases in the United States, and he found out that if somebody became suicidal during the washout period, it was added to the placebo period with the argument, well, they didn't get any drug, okay? And if they became suicidal after they came off the drug, it was conveniently removed and added to the placebo group because, well, they didn't get any drug, but it might have been caused by the drug because of abstinence, but they were added to the other group. Pfizer, GlaxoSmithKline, the big earner to your national economy in this country, Eli Lilly, they all did the same. This I call cheating. Now, what about people at my age? Well, they seem to be very harmful, antidepressants. There is a beautiful British study where patients were their own control. So in one period, they didn't get a drug. In another period, they did get a drug. So it was the same patient. And what happened? Well, if you treated just 28 people for 1 year, you killed one of them with an SSRI. That's a death rate of 3%. This was so unbelievable to me that I wrote an email to the first author and we exchanged views, and there are more studies than hers. I must say that they are dangerous, very dangerous in the elderly. And we know some of the mechanism because elderly people tolerate psychiatric drugs very poorly. Everything that affects the brain, they tolerate poorly. So they might fall, lose balance, fall, and break a hip. What does that mean? 1/5 of people who break a hip will be dead within 1 year. That's one of the mechanisms. There are more mechanisms, but this is one important one. So I believe that this about, well, GPs and psychiatrists don't even keep antidepressants out of reach of children. It should be forbidden to use these drugs in children. They drive them into suicide. But actually, I think they should be taken off the market because they don't work and they cause a lot of harm and produce a lot of drug addicts. Why not take them off the market? That would be far better. And then people say, what's the alternative? What's the alternative to antidepressant drugs? Simple. No antidepressant drugs. People always start arguing, well, psychotherapy isn't always that effective and it depends on whether the psychotherapist is good or bad. And yes, all true. But psychotherapy is another discussion. The alternative to drugs is no drugs. It's very easy. We would have far healthier and long-lived populations if we said no to psychiatric drugs. Now, Violence submitted to the FDA reports of that. 400 of them were homicide. And look that antidepressants, sedatives, hypnotics like benzos, ADHD drugs were particularly often reported among the reports of violence and murder. These drugs seem to be dangerous. Now, an Australian forensic psychiatrist studied 10 people that had mutations in their liver, which I think roughly 10% of people have, which gives them a wrong concentration of antidepressants in their blood. And look what happened. First of all, antidepressants are used for all kinds of foolish, non-existing reasons, like sister had a car crash, husband was drinking, I had difficulty with relations, or anxious about not making enough money. That's not an indication for an antidepressant drug. And what happened? Well, killed teenage daughter in toxic delirium after 3 days. Violent akathisia predisposes to murder for 14 days. Killed father 4 days after he ran out of pills. Abstinence symptoms. These people are not themselves. They act in out-of-character fashion. And it goes on like that. You don't need to see all of this. It's very, very sad. Harassment at work, you don't use antidepressants for that. All 10 people were able to stop taking antidepressants, often against their doctor's advice, despite these horrendous acts. The doctors still lived in their fantasy world and felt these drugs are good for you. They were against them coming off them. But they did come off them, and what happened? They actually became themselves. This is a very, very sad story about what we are doing to people with our drugs. This study has already been mentioned. This is the only one I know about where there was a long follow-up after a randomized phase, and you know that in schizophrenia, more people had actually recovered if you reduce the dose or stopped altogether. And actually, 11 had stopped in the dose reduction group, only 6 in the active maintenance group, and also they used more drug in the maintenance group, and yet the result was better in the drug with discontinuation group. Now, a little about psychiatric deaths. I have tried to estimate how many people do these drugs kill. It's not easy. The randomized trials are totally unreliable. Therefore, I used randomized trials in dementia, arguing with myself, these old people likely were not in antipsychotic treatment before they received one. So no abstinence symptoms. And what did that show? It showed that if you treat 100 people with dementia with an antipsychotic drug for a few weeks, you kill one of them, compared to placebo. For the other drugs, I didn't have good randomized trial evidence, so I needed to find good observational studies. So you can criticize my estimates, but these are the best I have. In those aged 65 or above, more than 500,000 deaths annually in the USA and Europe. This makes psychiatric drugs the third leading cause of death after heart disease and cancer. Isn't it time that we do something? And likely all drugs can cause chronic brain damage, and they often lead to addiction. And what I call psychiatrist silverbacks on drug company payroll have helped the companies hook more than 1 million patients worldwide on drugs most of them didn't need. And when problems arise, they typically say, blame the disease, never the pills. So antidepressants, don't use them. ADHD drugs, don't use them. They are harmful. Anti-dementia drugs, don't use them. Even in these flawed, non-blinded trials, the effect is so small that it has no clinical relevance. And they have a lot of harms, these drugs, so they shouldn't be used. Antipsychotics, 8% of current usage at most. I've actually come to the point where I say, why not drop them altogether? Because if you have an acute painful psychosis, benzodiazepines are good drugs. They calm people down faster than antipsychotics do in randomized trials. These trials are not very good, but there are 14 of them in a Cochrane review. So I'm not sure we even need antipsychotics. Throw them out to the fishes. So I think we need only 2% of current drug usage at most. So we have an overdiagnosed and overdrugged population. We have hundreds of thousands of deaths over the decades, more than 100 million mental and physical cripples over the decades. I cannot think of any bigger disaster on healthcare than psychiatric drugs. It doesn't exist. It is incredible that the leading psychiatrists cannot see what they are causing. I just don't get it. So what do we need? We need detox clinics everywhere. We have far more legal drug addicts than street drug addicts. We need these clinics. We need these detox clinics everywhere. And we need psychotherapy. It actually is a good treatment that learns people how to cope with life difficulties. A pill just numbs your feelings. It takes away your thoughts. If it's an antipsychotic, you don't learn anything, quite on the contrary. So psychotherapy also seems to have better long-term outcomes than drugs, which is not surprising as drugs have very poor long-term outcomes. And then we should ban forced admission and forced treatment in all nations. International convention.
Thank you. So I'm just going to have to ask you to hold it down until we have questions. I appreciate you're feeling quite emotional about what you're hearing. I understand that. Many people in this room will be as well.
Forced admission and forced treatment cannot be justified scientifically. It's harmful. It can't be justified ethically. It's discriminatory towards people with psychiatric problems compared to other people with handicap. And it cannot be justified legally either, because you discriminate people in front of the law by having separate laws for people with psychiatric problems. And the United Nations Convention on handicapped people says clearly that all nations must ban all laws that allow forced admission and forced treatment. All countries in the world, as far as I know, have ratified this. No one, not a single country does anything, and we must work on this with our politicians. It's only
Okay, thank you. Look, thank. Okay, let's stick with that. And Peter, if you can, we really appreciate you continuing.
Okay.
Thank you.
This is one thing I want to work on, and I gave my first talk on forced admission 2 days ago at a similar meeting in Copenhagen. I have a strong chapter in my new book about banning forced admission. There are very strong arguments for banning it. It's only when you send soldiers to war that you do something against their will that might kill them, and in psychiatry. We cannot allow this to happen. And I have a website where I publish various things where you can follow what I try to achieve. So it's called Deadly Medicines. And now I will end by showing you what I was sent yesterday by an Australian friend, and I know the father of this person, whom I met in Australia. He wanted me to read this aloud, the father. My name is Garth Daniels. I live in Melbourne, Australia. Over many years, I've been so-called treated involuntarily at several Monash University teaching hospitals. My prescription drugs were mostly administered over and above the manufacturer's recommendations. That's because they don't work, and then people increase the dose. I also developed neuroleptic malignant syndrome, which is highly lethal. He survived. The most excruciating reaction I experienced was the manifestation of violent akathisia, where you cannot sit still. In November 2014, I was shackled in a 4-point restraint to a bed for 69 days. This is torture. My prescriptions were a combination of drugs which including 80 milligrams of Valium, diazepam per day. In May 2015, I was again shackled for 45 days and more polypharmacy coupled with intramuscular injections. On 22nd August 2015, I was given the first of 9 electroshock treatments without my consent. Electroshock doesn't work for schizophrenia. After which I was released from restraint. I desperately want to taper off these horrible drugs that have caused me permanent brain damage. I regard my treatments as a crime against humanity. Now they want to give me clozapine, which is also a dangerous drug, for which I have refused consent. I have 2 questions. Does anybody know a good international human rights lawyer? I have no alternative but to take my case to the International Court of Justice in The Hague. His father has studied law in order to discuss with the lawyers that have been flabbergasted about this person having a father that knew the law better than they did. But still he hasn't won in Australia. I regard my treatment as state-sanctioned torture. I would like to be treated in a drug detox center. I cannot find one in Australia. How do we start one? There are thousands of Australians in my position. General practitioners are those who prescribe most psychiatric drugs, 80 to 90%. The psychiatrists don't even know how to use them safely. So what about the GPs? They know even less. So one of my proposals is to put a ban on GPs and any other doctors and psychiatrists using psychiatric drugs. That would mean a dramatic decrease in the usage of these drugs and a much healthier population. They are far too dangerous to leave to GPs. And the other thing I wanted to tell you is that I published a pretty direct paper in the Daily Mail 3 days ago. And I collaborated with a journalist, Jerome Byrne, who is here today, I was told. I think it was Byrne who introduced this ending of my article, which I happily accepted, that we have now launched a war against psychiatric drugs. And this war against drugs is incredibly much more important than a war against narcotics, because very few people die because of narcotics compared to all those we kill with psychiatric drugs. So let us not focus so much on street drugs in the coming years, but on psychiatric drugs. Thank you.
There is lots of research on harms of antipsychotic drugs. We know so much about these drugs that we, in my opinion, actually should not use them. I think we can do well without antipsychotic drugs. They don't cure anybody, but in many cases they make a temporary psychosis into a permanent chronic problem. When you take them for a long time, you can acquire breakthrough psychosis, supersensitivity psychosis, so that you actually develop a psychosis because of the drug you are taking, which was supposed to work for your psychosis. It's a double-edged sword. If a patient is terribly disturbed and hasn't slept for 3 or 4 days, you can give that patient a benzodiazepine. You don't need to give that patient an antipsychotic. And when I lecture for patients and ask them, next time you get a psychosis, what would you want? A benzodiazepine or an antipsychotic drug? So far, not a single one has said an antipsychotic drug. They want a benzodiazepine because they are not so dangerous. So why is it we don't do what the patients want? This is inhuman and it is discriminatory. So one of the things we should get rid of in psychiatry is definitely forced treatment with drugs, because we cannot argue that we give these drugs for the patient's own benefit.
So Peter, you've called modern psychiatry a disaster. What do you mean by that?
Well, the brief version is that the way people use psychiatric drugs definitely cause much more harm than benefit. And 10 years ago, I wrote an article where I concluded that doctors are unable to handle psychiatric drugs prudently. So it would be better if we didn't have them, if we took them all off the market. Doctors often use psychiatric drugs for many years to the same patients, and that's definitely harmful.
Yeah. How can you explain the disconnect? Because, these drugs, they're approved by the FDA. You hear, from the majority of academic psychiatrists, these drugs are safe and effective. In fact, they need to be used more. We're underdiagnosing people. How can you bridge the gap between these two narratives? What people are hearing in the news and from the experts about them being safe and what you just said?
That's very simple, really. First of all, the mantra is that drugs are safe and effective. This is an impossibility. If a drug has benefits, it will always harm some people, so nothing can be both safe and effective. It's only a question about how frequent are the harms and how serious are they compared to the benefits. And then you need to balance these two outcomes.
So that was the first thing. The other thing is that drug regulators like the FDA, they have no responsibility for how doctors use drugs once they have been approved. And if they had such a responsibility, they should not allow what they allow currently. I have done estimations that our prescription drugs are the leading cause of death, ahead of heart disease and cancer. This will surprise many people, but I have published about this. And our psychiatric drugs, very surprisingly, are the third leading cause of death after heart disease and cancer. People don't realize this. Therefore, we need to inform the general public about how the situation is.
Mm-hmm. I mean, you mentioned that the drugs, or you alluded to them being used irresponsibly. How so? Why are these medications, in your perspective, being used irresponsibly now?
It's a funny question, Joseph, because you know very well the answer.
Mm-hmm.
It is far easier to prescribe a pill than to start psychotherapy. And you also earn much more money by prescribing pills, because it has been documented that sometimes doctors prescribe a psychiatric drug after a consultation lasting just 5 minutes. So you can prescribe many pills. And psychotherapy is better than pills in the long run. This has been documented. So we need to focus on helping people with the problems they have, in being human in our doctor-patient relationship, and not just handing them a pill. And then when you have done that, given them a pill, the problem is that if patients want to come off the pills again, perhaps because of the side effects, then quite few doctors, also quite few psychiatrists, know how to taper off the drugs relatively safely, very slowly and in a hyperbolic fashion, not by halving the dose every second week or so, but very slowly when you come down to small doses. Doctors don't know this, even though it is essentially a common clinical pharmacology knowledge that doctors should be aware about. And this is what you do in your practice. You help people taper off psychiatric drugs. So you know that it can be difficult. Few doctors are aware of this, and they interpret this as, well, you see, you still need the drug because you get depressed when you don't get it. This is like telling an alcoholic that tries to stop drinking, oh, you still need your alcohol because you're not well if you stop too quickly. That's very sad that doctors don't have this elementary knowledge.
And you know, to touch on that part of it, you know, one perspective someone could take from what you said is that, you know, these doctors are almost villains in a way, you know, that they know things should be done in a different way, but they are prescribing these medications because it's faster and there's more commercial benefit. Do you think doctors are really doing that, or are they just misinformed? Like, how much of it is really, you know, bad morals and ethics, and how much of it is they don't know any better? You know, the pharmaceutical companies, they have an agenda, and they are publishing controlled trial data that may skew the interpretation. The drugs seem more effective and safer than they are. I understand that. And then I also hear that you have organizations like the American Psychiatric Association, Royal College of Psychiatrists, which may also take a friendlier view towards medications because it benefits the profession and their standing. But what about academics? You know, we have leading academics that are meant to be objective voices who are heading our institutions. We have medical journals with editors whose reputations are there to make sure that honest advice and objective advice is getting out to doctors. What is happening with these other checks and balances when it comes to the narrative about medications?
Unfortunately, our best medical journals are part of the problem. This summer, The Lancet published an anonymous editorial, maybe written by its editor-in-chief, Richard Horton, maybe by some other editor, I don't know. But it was about 50 years with SSRIs, the newer type of antidepressants. And it was supposed to be weighing the balance between benefits and harms. But that was not what the editorial was about. I wrote a highly critical article about this editorial, which was more or less praising the drugs. And it did not weigh the benefits and harms, and it quoted a seriously flawed meta-analysis published in the same journal, in The Lancet, by some psychiatrists some years ago that I and others have also criticized very heavily. And I have seen this in other major journals as well. So they are part of the problem. So it's actually very difficult, both for doctors and patients, to get honest, reliable information about what these drugs do to people. So we need to work together to get the messages out. And,
why wouldn't a medical journal just simply publish, more honest perspectives on these medications? That seems like their job.
Well, why is it that both the British Medical Journal and The Lancet have published so-called state-of-the-art articles where you assume that here I will get the truth about these drugs? Mm-hmm. And then what I can read again and again is that they are far too uncritical. And for example, the risk of suicide with antidepressants, which has now been shown to be doubled, not only in children, but also in adults, by using FDA data. It's being trivialized in these articles, like, oh, you can safely take these drugs. And also, very often, they are described as highly effective, which is totally false, because in the studies that have been made of the effect of antidepressants is so small that it is far below what is clinically relevant. So an effect is not an effect if it doesn't matter, if it's only something you can detect statistically if you have very many patients. You need to have an effect that makes a difference to the patients. And this is not the case. But people ignore this again and again and again in these articles. I could turn the question to you. Do you have a better solution than this?
About the medical journals and the way they do. I mean, my understanding is that, and you can correct me if I'm wrong, is that with some medical journals, they don't want to rock the boat. That there is an accepted narrative about these medications, which is accepted by their colleagues and the other leaders in the space. They would be getting a lot of criticism from their peers if they were to publish a critical piece, particularly when it comes to psychiatric medications. The narrative about them, which in a large part has been constructed by American Psychiatric Association and different academic voices who have been, let's say, platformed by drug company money, is that these drugs are safe, the case is closed. Anyone who criticizes them is actually a dangerous person. This is someone who is nefarious. They have outdated views about mental health. They think people ought to pull themselves up by their bootstraps. And so they're afraid to publish something like that because they feel like they're going to get negative media attention. Someone is going to say, oh, look at the BMJ or the Lancet or JAMA. They're publishing this dangerous article right now that is going to scare people away from the medications. I think they're worrying about their reputation in the press because they would be going against the grain. I also think, and I've heard this as well, that a lot of journals actually make money from ads for drugs and reprints about certain articles which may be favorable about the medications. The drug companies will pay them to get 10,000 copies so they can give them to the sales reps and hand them out in medical at medical conferences and offices. And so I think there is just an incentive from the owners of the journals to simply say, well, it's easier for us if we don't publish these things. There's going to be less complications. It's financially, it will be a better fit. I think that's the problem from how I see things. As for a solution, I thought Cochrane was meant to be a solution, which is the organization that you started, but then didn't quite turn out to be the case. Okay, we're just about to talk about Cochrane collaboration. For some context, this is an international nonprofit of researchers and clinicians that was founded in '93, and its mission was to produce high-quality, independent reviews of medical research so doctors and policymakers could decide on the best evidence. For many years, it was viewed as the gold standard in evidence-based medicine because the reviews were rigorous, transparent, and they were meant to be free from industry bias.
Well, Joseph, I'm very glad that I turned the question to you, because what you just explained was excellent. I couldn't have done it any better myself. You are absolutely correct. And my research group has actually studied how much money that comes from the pharmaceutical industry to the major journals through advertising and selling reprints. It was very difficult to get this information. For example, the New England Journal of Medicine and JAMA refused to give us this information. And when we asked the New England Journal, but can't you then just tell us what percentage of your income comes from the drug industry and what percentage from subscribers, for example? They wouldn't tell us. I can tell you that not only me, but other people whom I work with have seen, let's say, the last 10 years, that medical journals and journalism in general, TV and newspapers, they have become more careful not to disturb those who feed them, those who have all the money. TV channels in the States are very dependent on advertising for prescription drugs, which is only allowed in the USA and New Zealand. And we don't allow it in the rest of the world because it's harmful. I have seen, for example, the British Medical Journal. I consider this the best journal in the world. I was on the editorial board for quite some years at that journal, and I loved it. It was prepared to challenge dogma when I was younger, but this has changed. The British Medical Journal has become very careful not to disturb big financial interests, and they have lawyers that tell them, oh, if Peter Gotzsche publishes this, you might get sued by this and that drug company. And then BMJ has an obligation to follow the advice of their lawyers. And then after a protracted process that may last 2 years, for example, ultimately my paper gets rejected. And I get quite disturbed by that, because why didn't they tell me right away so I didn't waste 2 years on it? And my colleagues have had exactly the same experiences. So you are very correct there. And when you talk about Cochrane, I was elected to the governing board with the most votes of all 11 candidates, even though I was the only one who dared criticize the Cochrane leadership. But the major funder of Cochrane, the National Health Services research unit, actually warned Cochrane that they should be careful that they did not review garbage. So their reviews became garbage. And Cochrane didn't heed the advice given by the National Health Service and me. And then a couple of years later, Cochrane's major funder disappeared, the UK National Health Service. So Cochrane came in big trouble, and several review groups
stopped existing because they didn't have the funding. I'm one of those who feel it's a big tragedy that Cochrane, that was such a wonderful and idealistic organization in the beginning, it has also succumbed to the forces that tell people that they should be kind to the drug industry, they should be kind to guild interest, to the psychiatrist guild interest, and not worry too much about whether what they publish is honest science. You may think I'm harsh here, but I build it on a lot of data I have studied carefully.
Well, I think that's a really interesting story because you co-founded Cochrane, I think it was in the 90s, and my understanding was it was to keep medicine honest.
Cochrane had a policy that up to half of the authors of a Cochrane review were allowed to get money directly from the company whose drug they were evaluating. If you ask the general public, would they be happy about this? You know the answer. So when I was elected for the
they want zero. They would want zero people taking money from the drug companies on the review.
Yes. So when I was elected, I started questioning this and said, we must get a situation where no one, as you say, is allowed to take money from the firms whose products they're evaluating. And I offered to rewrite the commercial sponsorship policy, which I did in an afternoon. It was very quick, but then I was told by the CEO's loyal subordinate, who was co-chair of the governing board and was director of the UK Cochrane Centre. So he was definitely afraid of Mark Wilson. We have documented this. He did what Mark Wilson wanted, and they then launched an investigation among Cochrane people. What do they think about how the policy should be changed? This took Cochrane 2 years. And when they came up with a new policy, it was laughable. Now 1/3 of the authors were allowed to have direct conflicts of interest in relation to the drug industry. When I was interviewed by some UK organization about this, I said, well, this is like if you're cheating on your wife every second day, then one day you tell her, I have now improved. From now on, I will only be unfaithful to you every third day. How do you think the wife would react?
Yeah.
It's incredible. When I tell people this, they look at me in disbelief. Is this really Cochrane? Yes.
Is important to discuss now is that this is commonplace in academia these days. When I look at the so-called independent experts who are leading our academic institutions, whether it's Harvard or Yale or Stanford, almost all of them are heavily involved in drug company research. I'd be hard pressed to find a leader of any psychiatric program in any major university that isn't heavily involved in drug development in some way. That just seems to be the rule for academic ascension. You work with the drug companies, they help you with your research, they give you the protocols, they help write the papers. You get to use their editorial team to get things published. So they do a lot of the heavy lifting for you. They fly you around the world so you can be a speaker at conferences. You're working with these companies is a fast track to filling your CV with lots of articles and speeches and to really start looking like quite an impressive person. And it's to the point where most of these academics, they're heavily compromised now. And so I could see the people at the Cochrane saying, well, maybe 1/3 is okay, because where are we going to find any academics who aren't compromised? now, or who aren't working with drug companies. It's become so normal.
You are absolutely right. 4 board members resigned in protest over my expulsion. And one of them said that the Cochrane leaders had told him that if they prohibited authors that got money from the industry, they would have difficulty finding Cochrane reviewers. So that's one of the reasons. You're absolutely right. And in 2013, I published a book with a very blunt title, Deadly Medicines and Organized Crime, How Big Pharma Has Corrupted Healthcare. This book became a bestseller, and it has come out in 18 languages and will now come out in Hungarian, even though it's 13 years old. And I mentioned the book because in that book, I describe exactly what you just mentioned, that in America, deans of medical faculties and department chairs often receive sums from the drug industry that are totally obscene, seen with European eyes. They are so big that the corruption is huge. We are not talking about small money here. We are talking about a corruption that is quite pervasive.
I was recently revisiting a book which I think is quite a good one. It's Bad Pharma by Ben Goldacre. And there's a chapter right at the end of the book. He talks a lot about pharmaceutical corruption, and he talks about his girlfriend, or an ex-girlfriend of him. You know, they were both in medicine together, and they're discussing, and he's talking about this, how in awe you are as a junior academic when you start working with the pharmaceutical companies, because all of a sudden you're invited to dinners with all of these academics who, you know, they're all working with the drug companies. They're considered the giants of the field. They're leading the research. They're writing the guidelines. And it's just such a part of that community that you're not going to start criticizing drugs or criticizing the way things are happening, because you finally have a seat at the table to be with the leaders of the space. And if your whole career has been, you know, I want to get ahead in academia, you're going to learn very quickly about the things you can say and the things that you can't say. And you are going to shape your behavior so you can fit in with that group. And it's just so pervasive about how the money from the companies comes down, and it shapes a whole culture of medicine, and the things that you want to say and you can't say, and just through the social parts of it. I really enjoyed that bit of the book because you can see it. Yeah.
Thank you. Yes. And I can give you 2 funny examples. I was once the daily leader of the Nordic Coordination Office for AIDS trials. So we were studying new drugs against AIDS. This was in the beginning of the AIDS epidemic. And I went to Paris for a one-day meeting with a big drug company. And there were people from various countries, and we discussed with the drug company various proposals that we might be interested in doing, financed by the drug company, but provided that we were totally independent, that we would write the protocol, we would do the data analysis, and we would publish without the company having any influence on that. It was very unusual that this particular drug company actually accepted these conditions, which means that they could not manipulate our research. So this will very rarely happen, that you can make a drug company accept this, but they did. And you know, when the day was over, we were invited to a fabulous dinner at Hôtel de l'Opéra in Paris, a very famous place. And the leader from the company, he gave me an envelope after the dinner and said, "Thanks for your contribution today." And I went home and I expected to see some nice words in there, which there were. But there was the biggest money bill I had seen in my whole life.
a $1,000 bill.
Wow.
It was in the envelope. What do I do with the $1,000 bill? I think the guy had already gone home to America. I stood there with $1,000, and then I realized, oh my goodness, they have many subtle ways of making people corrupt. And the other example I will give you, I was in Switzerland, where I met a woman who once worked for a Swiss drug company in Basel. And one day she was given a stack of brown envelopes. So she was going to Denmark, Sweden, and other Nordic countries with these envelopes, and she were going to hand them over to leading physicians in these countries. And then she asked, well, that's an odd assignment. I mean, we have mail, you can post, but why am I going to deliver this personally? And they didn't want to reply, but she was persistent. What's inside these envelopes? Dollar bills. And if she asked more questions, she could find herself another job, which she did. She went into public health.
Wow. Way now, because I want to talk about solutions. I'm gonna do a recap first. And so we have a situation right now where academics are compromised, medical journals are compromised. The media, and we touched on that briefly. The media, they get a lot of funding from the ads of pharmaceutical companies. They don't want to bite the hand that feeds them, and doctors, because of this, are very poorly informed when it comes to accurate information about the drugs. What is the solution to this? From having seen all of these issues, how do we change things?
Well, the solutions are the hardest part. If we think about public information, there are also problems. For example, I have written a book about vaccines where I document that the Centers for Disease Control and Prevention in the United States, they are praising the influenza vaccine to an extent that not even the drug companies would dare do, because they have claimed on their website that influenza vaccines save lives. This is simply not true, and it's very unlikely to be true, and there are many other problems. So the idea of having publicly information that comes from public sources might not even be the solution, because, for example, it has been documented that the CDC receives money from the drug industry. They are channeled to the CDC via some mechanism they have, but they are nonetheless partly funded by the drug industry. And you know that the FDA is funded by the drug industry to a large extent. I've been active in the European Parliament as a kind of scientific lobbyist. I succeeded to convince the European drug regulator that I should get access to clinical study reports the drug companies had submitted to them to get their drugs approved. They declined to give me the reports out of commercial confidentiality reasons, and I complained to the ombudsman. And after 3 years, the European drug regulator had to give me the reports. So I opened the archives of the EMA in Europe, and I became quite popular in some parties in parliament. And I went there and worked on legislation to create even more access to data at the drug regulator, which we succeeded creating. So the EMA became far ahead of the FDA in terms of openness about the material they have. And that was because of what I did 15 years ago, or it actually started 18 years ago. So this is my biggest achievement in my whole academic career. As part of that, I worked with several politicians. We use this access to the clinical study reports, which can take up thousands of pages for just one trial, to show how dangerous antidepressants are, that there are many more cases of suicidality, of suicide attempts and suicidal thoughts and so on, than what gets published in the medical journals. And we also found examples of violence, thoughts about homicide and things like that, that don't get published. Now, I am an expert witness in lawsuits against Merck's HPV vaccine that is called Gardasil. That is in America. And as an expert, I have been able to read 112,000 pages of internal study reports Merck has produced on Gardasil. This corresponds to 500 books. And of course, I didn't read every single page because some pages were about laboratory values. But I published a book this week, a few days ago, about how Merck and drug regulators have hidden serious neurological harms of the HPV vaccines, which you have heard about for many years, but which the authorities have refused exist. This is not true. I could see how Merck had deliberately, I write in the book that I believe Merck has committed fraud by not alerting not even the drug regulators to serious neurological harms. We have examples of this. So this tells you once again that if you want to know what drugs do to people, don't go to the medical journals. You need to go to the sources, the clinical study reports. And may I give you an example from psychiatry about this?
Yes.
We had access to the study reports Eli Lilly had produced on fluoxetine called Prozac in America, which was praised as a wonder drug when it came on the market. It is anything but a wonder drug. So with psychiatrist David Healy, I went through these study reports of some 1,000 pages, and then I could see that, for example, 2 suicide attempts, and we are talking about children. These reports were about fluoxetine in depressed children. And in one of the trials, 2 suicide attempts on fluoxetine had been left out of the publication, but we could see it in the clinical study report. So the mantra for the drug industry, as you said early on in this conversation, is that the drug is effective and safe. So this is what the drug industry always says, and also drug regulators. So David Healy and I wrote an article where our conclusion was fluoxetine is unsafe and ineffective, because that's what we found.
I think, when we look at solutions to this issue, I was reflecting on that as I asked you, and there has to be some regulation. This problem is so big. The medical journals, the peer reviewers, they shouldn't take money from drug companies. Medical journals shouldn't be taking money from drug companies if they're publishing. Academics, the people leading the academic institutions and training the next generation of doctors, their teachers shouldn't be taking money from drug companies. I also think, we have to have some kind of regulation at a government level that actually protects against censorship, such as, when different doctors, they want to talk about problems with vaccines or they want to talk about problems with drugs. Right now on social media and different places, these videos are being removed. People are being punished by their academic institutions. They're being attacked by their medical boards. And so even free speech about these medications is being challenged right now. It's grim when I reflect on what the solutions would have to be to solve this problem.
Let me give you a few hints. In June, I was in Washington, D.C., where I met with you, actually, and your wife. We attended a meeting on veteran suicides that the suicide prevention program in the United States involves to give people antidepressants. And when the veterans that were war traumatized got antidepressants on a larger scale, the suicides went up, which would be expected because this is what the drugs do to people. So I gave a lecture about this in Capitol when I was there. And I also had the pleasure of interviewing Jay Bhattacharya, the new director of the National Institutes of Health. And I had a planned meeting with Bob Kennedy, your health secretary, but unfortunately he had an emergency, so I just went to him and spoke very briefly with him. I've also interviewed Martin Kulldorff twice, who was one of the three authors, together with Jay Bhattacharya, of the Great Barrington Declaration that told us that we should not lock down our societies because it would be very harmful. And Jay and Martin have been absolutely correct, because Sweden was the only country in the world that didn't lock down. And they have had a lower mortality overall in the population during the COVID pandemic than other countries, because when you lock down, you increased mortality from other reasons. Some people with pain in their chest didn't dare go to the hospital because they were afraid of getting COVID infected. And then they died from their heart attack at home. Kennedy knows that I disagree with him about some opinions on vaccines he has, but I also agree with him that it is very wrong that new vaccines are not tested against a placebo, but against another vaccine that might have similar harms as the vaccine you are testing, which means that then you won't find out which harms your new vaccine has when you don't have a placebo control. That's just one of Bob's things. And as you know, he has kicked out the whole CDC Vaccine Advisory Committee and has employed a new one where Martin Kulldorff is sitting and other good people. So the CDC's Vaccine Advisory Committee is now no longer corrupt, because those who sat there before, they had ties to the drug industry. This is not acceptable. So what I see right now in America gives me some hope for the future.
We certainly are at a very interesting moment in time in the US when it comes to awareness about these issues, and I do hope it continues.
Drug companies are the most wealthy business on the planet. They have so much money that it's unimaginable, and they buy everyone with an influence, including sometimes ministers of health. And of course, when they buy doctors, they start with the professors and chairmen, chiefs of department, and then they educate them so that they can become what they call key opinion leaders, so they can indoctrinate other doctors that some terribly expensive drug should be used and not a cheap one, which might even be better or having less side effects. Medical education is partly corrupted. No doctor should ever go to any educational event where the drug industry has put money in it. Of course, they don't select key opinion leaders that are not good salespeople for them. And if they start talking about harms of the company's drugs or start praising a competitor's drug, of course, that person wouldn't show up next time. That's obvious. My country, Denmark, is regarded as one of the least corrupt countries on earth. But I must say, on healthcare, in healthcare, we are pretty corrupt like the rest of the world. In Denmark, we have transparency about whether doctors get money from the drug industry. And in our little country, where we only have around 25,000 doctors, thousands of them are on the advisory board of a drug company, or consultants, or they lecture at drug company funded continuous medical education events. This is how you buy influence. You buy people, and then you buy their loyalty. I mean, 1,000 people on the advisory board of drug companies in Denmark, what should all these doctors be doing? They don't do much, most of them, but they are being bought.
I know you answered this question on your book about on critical psychiatry, but I think the suggestions that you give at the end of the book are really interesting for the people. So the question is there any future for psychiatry?
I have written several books about psychiatry. Which one are you talking about?
I'm talking about critical psychiatry textbook.
Okay. Okay, I published this myself this summer in July. I read the 5 most commonly used psychiatric textbooks in Denmark. They are used by medical students, by students of psychology and psychiatry. I found so many errors in these books that I wrote my own book, which is more honest, where I point out what is wrong with these textbooks. And it's the same all over the world. And then I gave some recommendations in the back. But the most important one is that psychiatry should be abolished. So which other things are you thinking of?
Mm-hmm.
For example, I also have a suggestion that in the meantime, before psychiatry gets abolished, those in charge of psychiatry should not be psychiatrists because it's too dangerous for the patients. It should be psychologists who are not in favor of psychiatric drugs, because some psychologists try to behave like psychiatrists, and this gives them prestige. And so they are positive to psychiatric drugs. But we really need psychiatry to be run by social workers and psychologists that are not positive to psychiatric drugs. This should happen.
Mm-hmm. Yeah, we psychologists, and this is a conflict of interest, a declaration of conflict of interest, because I'm a clinical psychologist. We feel we have to prove we are effective playing other game, like playing with psychiatrist rules, because we have to fit in all of that biomedical construction of mental illness. And we, at least some of us, are critical with this conception. We don't focus on brain that have to change, but on a person and his behaviors, emotions, and thoughts, and the role of his relationship with his environment. So the question is, what do you think it could be the role of we clinical psychologists, which is what you have talked a bit about, and in this job of changing all of these psychiatric practices, and how we psychologists can do better in this job?
Well, good psychologists are already doing pretty well because they know the importance of talking to people and listening to them and finding out what happened to them in the past. This is so vital for psychiatric patients to be heard and understood. So I think you're already doing quite well. Before this interview, you wrote to me that there are also problems with psychological research. And this is, of course, true that some studies of psychotherapy are also biased. For example, because the examiner of the effect is not blinded, but knows whether the patient got psychotherapy or just some kind of usual talk and caring. But even so, it is obvious that psychological therapy can be effective, and it doesn't kill people, which psychiatric drugs do. In my book from 2015, I tried to work out how many people are killed by psychiatric drugs. So I studied the randomized trials, and I studied good observational studies where people with and without drug usage were being compared. And I came up with a devastating result, namely that psychiatric drugs are so harmful that they may be the third leading cause of death after heart disease and cancer. And I'm fully aware that this estimate might be exaggerated, but I went to the best research I could find. And even though it's not the third leading cause of death, it might be the fourth or the fifth leading cause of death. And this is very, very bad for drugs that don't really help people, but make it more difficult for them to live a normal life. So there are so many good reasons why we should not use these drugs. Apart from very acute situations where a patient is totally deranged and cannot sleep and has a terrible time, but then we don't need psychosis pills. We can just use benzodiazepines, which are not so dangerous. And they even seem to work better in an acutely disturbed situation. But of course, these drugs are very cheap. So you will have difficulty finding any psychiatrist or drug industry, not any drug company, that will recommend these drugs instead of psychosis pills.